Hi, welcome back to IU Radiology Case of the Day. My name is Tim Tsai, and I'm a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting abdomen case. I'd like to give a shout-out and thanks to Dr. Swenson for his help and, of course, Dr. Coons for organizing the entire Case of the Day initiative. All the content in this presentation has been fully de-identified to protect patient privacy. For this case, we have an incidental finding encountered during a lumbar spine MRI of a 65-year-old woman. Here are multiple T2 axial images. Take a moment to inspect them. Alright now, what are the findings? What is your differential for this case? And what would you look for next? Finally, what is your diagnosis? Let's go over the images. We see that there are innumerable 1 to 2 millimeter round T2 bright renal lesions both in the renal cortex and medulla. The kidneys are also normal in size. No other lesions are shown in the kidneys, adrenal glands, or pancreas. There is an incidental left extrarenal pelvis. This is a case of lithium nephropathy. While lithium is an effective medication for bipolar disorder, one of the unfortunate trade-offs is a number of nephrotoxic effects. Lithium nephrotoxicity can be classified as acute lithium intoxication, nephrogenic diabetes insipidus, and chronic renal disease. Acute lithium intoxication is not infrequent due to its narrow therapeutic index, and renal manifestations include polyuria and polydipsia. More commonly are neuropsychiatric symptoms, as well as symptoms such as nausea, vomiting, and diarrhea. Nephrogenic diabetes insipidus is the most common complication of long-term lithium treatment and affects approximately 20 to 40% of patients. It's usually reversible with a benign course. Chronic lithium nephropathy can occur after 10 to 20 years of lithium therapy and results in chronic renal insufficiency. Lithium nephropathy is well demonstrated on MRI as 1 to 2 millimeter microcysts in the renal cortex and medulla. The kidneys are notably normal in size, which helps distinguish this condition from other cystic renal diseases. The cysts likely originate from the distal tubular structures and collecting ducts, and are reflective of chronic tubulointerstitial nephritis. The differential for multiple renal cysts includes a host of hereditary and acquired diseases, and attention to kidney size, the size and location of the cysts, and patient history helps differentiate between them. Hereditary causes for cystic renal disease include autosomal dominant polycystic kidney disease, glomerulocystic kidney disease, medullary cystic disease, tubular sclerosis, and von Hippel-Lindau. Acquired cystic renal disease more commonly occurs as a result of dialysis. However, lithium nephropathy also results in renal cysts. Renal cysts, of course, can also occur incidentally with age. So for hereditary causes of cystic renal disease, most commonly there is autosomal dominant polycystic kidney disease, resulting from mutations of the PKD1 gene. The kidneys are enlarged, containing multiple cysts of varying sizes. Liver cysts may also occur. Glomerulocystic kidney disease is also in the differential and occurs as a familial or sporadic condition. This is more common in children and young adults with small cysts in the cortex of small to normal-sized kidneys. Medullary cystic disease is an autosomal dominant mutation of the MCKD1 or MCKD2 genes resulting in adult-onset renal failure and gout. The kidneys are small to normal in size, with small cysts in the medulla and corticomedullary junction. The cortex is also thin. Tuberous sclerosis can have multiple renal cysts. However, TS patients more commonly have angiomyolipomas, up to 80% as opposed to 50% for renal cysts. Patients with tuberous sclerosis develop RCC at a similar rate as the general population, but at a younger age. Aside from the number of neurological, skeletal, and skin manifestations of tuberous sclerosis, patients are also prone to developing pancreatic neuroendocrine tumors. Von Hippel-Lindau can also have renal cysts, which may be simple or complex. This is in addition to the propensity to develop cystic clear cell carcinoma of the kidneys, pheochromocytomas, pancreatic cysts, and other pancreatic tumors. As for acquired adult cystic renal diseases, dialysis patients will have small atrophic kidneys and cysts of variable size, rather than the uniform 1 to 2 millimeter cysts in normal-sized kidneys, such as in chronic lithium nephropathy. If you'd like to read more on these entities, I like this paper by Drs. Wu and Wadhwa. To sum it all up, chronic lithium nephropathy can show up on MRI as numerous 1 to 2 millimeter renal microcysts scattered throughout normal-sized kidneys. These changes occur after 10 to 20 years of lithium use, and patients will have chronic renal insufficiency. There is a host of differential causes for adult cystic renal disease, and differentiation from the other hereditary and acquired causes necessitates a little more digging into the chart, attention to kidney size, the size and location of the cysts, and any other findings. So as always, thanks for tuning in to the IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials at the website below. Thanks so much and have a great day.